Good morning. Almost good afternoon. All right, so we'll get started. So welcome to Plenary IV. My name is John Silas. I'm from the European Observatory on Health Systems and Policies and the WHO Barcelona Office for Health Systems Financing. So in this plenary, we're going to talk about health spending. So if we look, since the Tallinn Charter was signed in 2008, government spending on health in the median European country has grown from 4.7% to 5.7%. And this increase in spending has, of course, occurred by substituting away other types of public spending. So the median country in the European region in 2008 spent just under 12% of its government budget on health. By 2021, due to increases over time as well as the pandemic, that had increased to 14%. Now, these increases in public spending on health, while they've been very good for countries to progress towards universal health coverage, and they've been very important for pandemic responses in many countries, it's important to note that there's still a lot of variation across countries. So if we look across the region, the country that spends the most per person from government funding on health spends more than 400 times as much per person as the country that spends the least. But nevertheless, whether countries are high spenders or low spenders, these increases in spending have occurred in almost all countries in the region, and it's fueled concerns about sustainability and about whether countries can continue to afford to pay for healthcare, especially if health spending continues to outpace economic growth. And so this raises important questions. Should countries in the European region spend more of their resources on health as their populations age, as new technologies come onto the market? Or can countries progress towards universal health coverage and transform their health systems on their current level of government spending, if only they can figure out a better way to spend? So these are the questions that we're going to talk about in Plenary IV, the spending more or spending better. So with this in mind, and again noting that there's lots of variability across countries, we're going to do a Slido, if it works. Big unknown. Oh no, it works, okay. So take out your phone. Give this a minute. Okay. Let's go to the question. Maybe if we could switch to the Slido, otherwise I will use my phone. All right, well, I'll tell you the question as it comes up. So, can your country improve its health system performance and progress towards universal health coverage given its current level of public spending on health? So yes, we spend enough already on healthcare. We just need to reduce inefficient spending, and whatever is saved, there we go. And whatever is saved can be spent better. Or no, we need to spend more on healthcare if we're going to improve both outcomes and financial protection. And for anyone not sure, there's the not sure. Okay, so far, a lot of people, it's getting closer. So it looks like most people, I guess there's still some more votes coming in, think that in their country they need to spend more on health. Sorry, maybe some people are still, let's see. No, I think that's good. Okay, so to help us think through this question a bit more, I'm very pleased to invite our keynote speaker, Dr. Ashish Jha, to the stage. Ashish told me before we started today that I should introduce him as someone who gives hard truths to policymakers. And I think that this is a really good introduction, someone that tells it like it is. Ashish is the Dean of the Brown University School of Public Health in the United States. He's a globally renowned public health leader and physician with over 300 publications. In March of 2022, Ashish was appointed by President Joe Biden as the White House COVID-19 response coordinator, where he led initiatives that enhanced treatment, vaccine accessibility, improved testing, and strengthened national stockpiles. He's also held prominent positions at Harvard. Ashish, many thanks for coming all the way here. The floor is yours.
Great. Thank you. All right. Good morning, everybody. So, as Jonathan said, from the United States, it's always tricky to come to any place in the world and talk about healthcare spending when you're from the United States. I am going to spend the next 20 minutes or so basically making 3 points. And let me just make those 3 points up front, and then if you want to just leave and go get coffee, you can do that, or you can hear me talk through them. The 3 points I want to make are, first, that there is very good evidence that more spending leads to better health outcomes. Not always, not in every country, but as a general rule, it is undoubtedly true. And we'll see this from some of the data I'm going to show, and I think there's lots of data in this fantastic report that is in front of you on financing for health system transformation, that more healthcare spending generally leads to better health outcomes. The second point I want to make is there is a belief in the policy world, in the health policy world, that social spending can be a substitute for healthcare spending. That because social determinants of health matter, because social factors drive so many health outcomes, if we invest more in social services, we can invest less in healthcare. And while that is theoretically true, at least I'm going to argue that that is practically very, very difficult to implement. And the reality is that social spending and healthcare spending tend to go up or down together, and that they're closely correlated. And the last point I want to make is there is lots and lots of opportunities for improvement. That no matter what your level of spending is, there are lots of things you can do to improve that spending. And so it should, while we need to think about more spending on healthcare, and I thought the little survey that Jonathan just put up was very interesting, that about 60% of people in this room thought that your health system needs to spend more to achieve universal health coverage, needs to spend more to improve access and quality. I think that's true for most countries, but the bottom line is it's not just about spending more money, it is about spending money better, and we'll talk a little bit about that. So those are the 3 main points I want to cover. And I have some slides which I'm going to go through reasonably quickly because I want to spend less time going through slides. So there's actually an error in this data. Canada is at about 11%. But if you begin by just looking across the world, first and foremost, US is an outlier. This is slightly old data. The latest Health at a Glance from OECD has actually more recent data. The key points here are US, just a complete outlier, about 17, 18% of GDP. By the way, and I'll show you some data in a bit, the driver of US healthcare spending is prices. It's not utilization, it's prices. America just spends more on everything. The second point is if you look at the highest income countries in the European region, in the OECD, they tend to spend around 10, 11% of their GDP, 9 to 11%. That's largely where things, and by the way, I'm talking about total spending, so this is not government spending. It includes a lot of out-of-pocket spending. But if you look across the European region, Germany, Switzerland, they're at kind of one end, at 11, 12, 13% of GDP. You have countries like the UK and France, sort of more in the 10 to 11% range. Finland is about 9.5, 10% of GDP. Portugal, Italy, around 9%. Estonia, our wonderful host country, closer to about 7% of GDP, along with Lithuania, Cyprus, Hungary. Sat next to a colleague from Hungary yesterday at the ministerial lunch, about 6%, and then Kazakhstan down to about 4% of GDP, and that's total spending. That's not just government spending, that's private spending. So the point is, there are large variations, threefold variations, just across the European region. Right? Very, very large variations. And it is interesting to ask the question, does everybody need to spend more? And I will show you some data in a second. It is undoubtedly clear in my mind that if you are at 4, 6, 7%, you probably need to be spending more. Whether you're at 12, 13%, or 17, 18% as the US is, you need to be spending more. That's a conversation we can have. But I think the overwhelming data suggests that people generally need to be spending more. And let me get to some of that data in a second. The second piece of data I want to just start off with is showing the variation in social spending across countries. Social spending is measured in lots of different ways. This is, again, using OECD data. This is a combination of education, welfare, spending on the elderly. And what you can see is lots of variations across countries in terms of how much money. And again, this is both public and private. And the reason to have both is different countries have different social spending strategies. So in some countries, all the pensions are public, while in other countries, pensions are all largely private. And ultimately, what you care about is what is the social safety net that people are experiencing, less about exactly is it coming from government or the private sector. So let me actually get to this slide. Now, this slide shows a very clear relationship between healthcare spending and life expectancy. If the US were dropped from this slide, that relationship would get even stronger. The problem is the US tilts everything because we spend an outrageous amount of money and have terrible health outcomes. We have figured out how to achieve both a very expensive healthcare system that fails to cover everybody and has bad outcomes. Again, I'm happy to have a conversation about why America has managed to achieve these goals. But if you took America out of the mix, the relationship between health spending and life expectancy is strong and consistent really around the world, and this is just using OECD data. So that's somewhat, in some ways, point number one. And if you ask the question, kind of what's going on? Why does healthcare spending lead to better health outcomes? The point I like to make, and I've been a professor at a public health school for most of my life, and my friends in public health don't always love to hear what I'm about to say, but most good things in health cost money. It's very rare that health spending or health services actually save money. So people often talk about prevention saves money. Most prevention doesn't save money. Vaccines are the one exception. Childhood vaccinations and even adult vaccinations pay for themselves. But if we think about things that the health system does for prevention, we talk a lot about primary care, hypertension control, extremely important, cost-effective, not cost-saving. Right? And there's a difference between cost-effective, where you're spending more but you're getting good health outcomes, versus cost savings. Diabetes control, cost-effective, not cost savings. Cancer prevention, mammography, colon cancer screening, these are all really, really important things to do. We should be doing more of those things. They all cost money. And at the end of the day, none of them are cost savings unto themselves. So the reason why there is a positive relationship between healthcare spending and health outcomes is almost all the things that drive health outcomes, at least through the health system, require more healthcare spending, whether that's primary care, whether that's prevention, whether it's taking care of critically ill people. Quality costs more money. We've had a conversation about improving quality of services, accessibility. There have been conversations about how do we make sure that primary care is available after hours. All of those things ultimately end up costing money. Last point I'm going to make is, you heard from Jonathan Silas. He has a really important paper looking at the impact of better health on the elderly. And one of the things that policymakers often think about and often talk about is, well, elderly are not economically productive in the way that we think about. They're often not working. And so there's a question of what is the social benefit of investing in health that benefits older people. Personally, I think the social benefits are overwhelmingly clear. From Jonathan's work and from other people's work, we know that when people are healthier, they're more likely to remain in the workforce. When people are healthier, they're more economically productive. So there are, and of course, it's a social good. We want people to be healthy, particularly older people. The bottom line here is there's a lot of social benefit to older people remaining in good health. That requires investments that are going to cost money. So big picture point number one, health spending leads to better health outcomes if you spend it well. And it's very, very rare that you're going to get health spending that's going to save money in the long run, as much as I wish that were not the case. All right. The second is this relationship between health spending and social spending. So at least in the United States and elsewhere, there has been this sort of belief that if we spend more on social services, we will save downstream on health. Theoretically, I think that is entirely possible. This is just not what we see in the data. So if you look at countries' social spending compared to their healthcare spending, we find actually a very strong positive correlation. And again, if you drop the United States from this, that relationship gets even stronger. And that's because it is rare for countries, when you think about how budgeting happens, and many of you are intimately involved in this, it's not that you say, okay, we'll spend less on healthcare so we can spend more on childhood education. Countries that prioritize social well-being and health for the population end up spending more on both things. Countries that prioritize those less end up spending less on both. So while it is theoretically possible that you could say, we're going to spend less on hospitals so we can spend more on early childhood education, I think that's entirely possible, that's not what we empirically see in the world. What we empirically see is countries that spend more on one tend to spend more on the other, and countries that spend less on one tend to spend less on the other. All right, so these are the sort of two main points I've made. I'm going to keep going. I want to really make the last set of points here about utilization, and I'm going to talk a little bit about prices as well, because this, in my mind, begins to give us a sense of how we might spend better. So I've made the case, whether you believe it or not, I've made the case that we need to be spending more as a general rule, and that more social spending will not necessarily get you out of this situation. But what about, how do we figure out how to spend better? So here's just some more data from OECD. This is hospital discharges per population. And what you see is very large variations across just a set of high-income OECD countries. And the reality is there's a threefold difference in hospital discharges per population between Canada and Germany. And if you look at, for instance, the three countries with the lowest hospitalization use, Canada, Japan, and the Netherlands. By the way, one point, just because I've been talking about America, there is this myth inside the United States and elsewhere that Americans use a lot of hospital care. Actually, we're slightly below the OECD mean in terms of hospital discharges per population. So Americans are not necessarily using a lot more healthcare, or a lot more hospital care. But again, you can see there are countries like Netherlands, Japan, Canada that use a lot less. That's hospital discharges. When you then go to the physician visits, interestingly, Japan, Netherlands, and Canada are among the biggest users of physician visits. There isn't necessarily a perfect correlation of a trade-off between outpatient care and inpatient care. There are countries like Germany that are high utilizers of both. But there is a bit of a trend towards more outpatient use, a little bit less inpatient use. And it does give us an insight into one way we can think about changing utilization. Now, this is very easy for me to stand up here and say that we need to sort of think about hospital reform and in some places with high hospital utilization, reducing hospital use. But I think as our German colleagues know, hospital reform is really hard. We've tried to do hospital reform in a variety of ways in the United States. It's very, very hard. So these are very hard things to move, but opportunities to at least think about. All right, I'm going to skip that. So just in the interest of time, what we see is large variations in utilization. Some countries just use a lot more health care than others, but I do think there are better opportunities for better care. Let me just get to the last point, which is about prices. This is pharmaceutical spending among OECD countries. And what you see here, and this is where America really is exceptional. All of our prices are just dramatically higher. Pick any topic you want, we pay more for it than anybody else in the world, by a lot. So we don't use more pharmaceuticals in the United States than Europeans, but our pharmaceutical spending is much higher because our prices are much, much higher, both for generics as well as particularly for brand name drugs. But you can see across countries very large variations in prices. This is generalist physician salaries. This is a few years old data. We pay our doctors more, we pay our nurses more, we pay our specialists more. But again, pretty substantial variations across countries. on physician salaries. This is real. This is about 7-8-year-old data from the International Federation of Health Plans. So some of this may be off by now. But if you look there, based on at least their data, CAT scan, again, you can see these very, very large variations across countries. So the big picture point here is that prices are another area, another important lever for controlling healthcare spending. We've done this before. So in the health crisis, or not the health crisis, sorry, the economic crisis of 2009, a lot of countries managed healthcare spending by lowering prices in terms of reimbursements, in terms of how much it paid in terms of physician salaries, nurse salaries. It has been done. It is a lever. I always remind people there are a couple of challenges when thinking about using price as a lever for spending. One is it's difficult when physicians and nurses get used to a certain salary. It's politically very, very hard to cut back on that salary. And given that labor costs are such a major part of the healthcare system, this is always a difficult thing to move. The second is that often, at least in the United States, I think this is true, but it's true elsewhere, we should be thinking as much about relative prices as absolute prices. And here's what I mean by that. In the United States, a 20-minute or 15-minute visit to an orthopedic surgeon is reimbursed at 3 times the rate of a 15-minute visit to a primary care physician. 3 times. Now, there's nothing written in stone that says has to be 3 times. That is what the health system largely does. And so even if you don't reduce overall prices for everybody, there are opportunities where certain things are just priced at a very high level to look across how much are we paying for MRIs, how much are we paying for CAT scans, for orthopedic surgery, and asking, are there places when some of those prices can be shaved without having untoward consequences? Okay, really just want to get to the maybe last point, except my clicker is no longer working. Oh, sorry, it was working. All right, let me get to the summary here, and then we'll go to the panel. Wow. See if this stays up. Okay. So let me just finish off, as I've said. The main point here, and again, we'll have a very robust panel, and I suspect we'll have people on the panel who disagree with this. I do think there is good evidence that more spending leads to better outcomes. When I think about opportunities for better spending, let me just actually take a minute to talk a bit more about this. I mentioned the idea of shifting more care out of the hospital into primary care. I think that is an important opportunity for lots and lots of health systems. Yesterday, I was sitting next to the health minister from Portugal who mentioned that there is an effort to do more what he described as ambulatory hospitalizations. This is a new idea that I think has a lot of potential benefit, which is instead of bringing people to the hospital, there's a certain set of people who can remain at home, who can remain in the nursing home, who can remain in some long-term care facility, and essentially get hospital-level care without all of the costs and all the complexity of transporting them to the hospital. Remote monitoring, sensors, other new technologies enable this in a way that I think was not possible 10 years ago. So really rethinking what needs to happen in the hospital. We have seen this a lot in the United States. A lot of surgeries that used to happen in the hospital now are getting done on the outpatient setting. So that is one place where I think smarter spending is very, very realistic. A second issue, which among my friends in the medical world often get me into trouble when I talk about this, is the issue of task shifting. I think there are a lot of things that physicians do today that nurses can do quite effectively, especially advanced practice nurses. And there are a lot of things that nurses do that community health workers can do, and so on. And technology here can be an important enabler again. Given what is happening with AI, with smartphone technology, I think arming a whole different workforce to do a lot of the things that required many, many years of training is becoming increasingly possible. And the question for health systems is going to be, are they going to be nimble enough, fast enough to shift To the extent that health systems are able to do it, I think that represents a real opportunity for real savings and delivering care more efficiently. And then last but not least, and this is something there's been a lot of experiment happening, I think across European countries, certainly in the United States, is brand new care models. New ways of delivering care in a way that we didn't used to. And I've talked about some of those, shifting things out of the hospital. During the pandemic, one of the things that we innovated on inside the United States in many cities is we set up mobile vans that went into communities to take care of acutely ill people. So instead of having every acutely ill person get in an ambulance, come to the emergency room, we equipped mobile vans that, with advanced practice nurses, these vans had tests, they had medications, they went into communities and actually provided care after hours. You didn't have to set up a whole infrastructure. It was both very efficient and very, very convenient. Thinking through new models like that can be extremely effective. And then, of course, we've talked a lot about this in the last day and a half, but things like telemedicine. And again, I think we are underestimating the power of artificial intelligence in all of this. I don't know how many of you have experimented with or played around with ChatGPT. It is extraordinary in what it can do. And if you type in some basic symptoms of a case, it is better than a vast majority of doctors in terms of coming up with a diagnosis, and that's today. Within a year, 2, 3, these systems are going to get very, very good. So really beginning to use them to create new care models, I think, is another opportunity. Let me just finish off by saying, we're entering a time period where I think you're going to see the development of a whole host of new treatments. One of the big things that we're thinking about a lot in the United States is GLP-1 agonists. These are things like Ozempic, other drugs that combat obesity. These are extraordinarily effective. And for all the data we have right now, extremely safe. And they are going to transform obesity. They're also incredibly expensive. At least right now in the United States, it's about $1,000 per month. So my point is that there is going to be more and more pressure to spend more and more money on healthcare. And I think that we have to understand that if we're going to improve the health and well-being of our populations, almost all of us, maybe not America, but most of us are going to have to spend more. And the challenge in front of us is how do we spend more efficiently? How do we spend more effectively? How do we get out of the old models of care delivery where everything has to happen in a hospital or everything has to happen with a doctor so that we can accommodate the new technologies that are coming down the pike? Anyway, thank you so much for listening, and I look forward to our conversation.
Thanks, Ashish.
I'll go sit.
Go ahead, take a seat. So, Ashish, I really liked your point about this idea that people think that if we cut health spending, then we'll have more money to spend on social services. And actually, that the evidence doesn't really show that to be the case, that it is really the higher spending countries that are the ones that are spending more on other social services as well. You don't get this sort of squeeze balloon effect that if we spend less on health, we have more money to spend on other things. So please go ahead, take a seat. Before we get to our panel, we have another Slido. So grab your phone. It's a test, actually. See if you were paying attention. No, it's not. So the next Slido. So the first question was about do countries need to spend more, or are they fine on their current budgets? Now, if countries are fine on their current budgets, what areas should they be prioritizing? Or if they're going to spend more, what should they be prioritizing? So the choices are, you're already voting, so I don't need to tell you, but primary care, prevention, which Ashish says is not typically cost-saving, recruiting and retaining health workers, digital technologies, mental health care, developing pharmaceutical funding models based on value, so very much this idea of putting pressure on prices, coverage policies that improve financial protection, very important, an excellent parallel session coming after lunch on this topic, or something else. Okay. A lot of primary care. Interesting. So primary care, digital technologies. Looks like Ashish didn't sway a third of people on prevention, or a quarter.
Can I just say, prevention is great. It's just not going to save you money.
Yeah.
That is not my way of saying prevention is not important. I would lose my public health license if I said prevention was not important.
Okay. Let's go to the panel. So I'd like to welcome up to the stage our very distinguished panel. So we have Riina Sikkut, Minister of Health, Ministry of Social Affairs, Estonia. Kaisa Juuso, Minister of Social Affairs and Health for Finland. Reinhard Busse, co-director of the European Observatory and professor Technical University Berlin. And David Wilson, program director in the Health, Nutrition, and Population Practice World Bank. So maybe applause for a panel. So Riina, the first question is for you. So you're Minister of Health of Estonia for the second time as of this past spring. But between 2022 and 2023, you served as the Minister of Economic Affairs. And a long time ago, you also worked at the Ministry of Finance. So you are a very unusual case of having dabbled in all sorts of both Ministry of Health and been a policymaker in Ministry of Health and Ministry of Finance and Economic Affairs. Can you share with us some honest insights as to what economic and finance policymakers want to see from the health sector if health systems are to obtain more financial resources?
Thanks for the question. And first, I want to confirm something that everyone seems to believe. Yes, it's easier to get additional budgetary resources as a Minister of Economics than the Minister of Health. If you want to pave roads, build ships, invest into electricity grid, I was surprised. Everyone says, yes, it's logical. And I thought, why? It seems so much more humane to invest into health, but if you invest into health, you usually want a behavioral change, whether it's in prevention or the way healthcare services are provided, the way hospitals are managed, the way doctors and nurses do their everyday work. But with paving the roads or investing into grid or building ships, you just need the political decision and money, and you can deliver. So that there is basically instant delivery. You usually get what you order, that there is no risk that, oh, the health outcomes, they're not improving, although I put 100 million extra in. But it never happens with paved kilometers. And the last thing I want to say is the prevention. You very often get, what do you mean extra money for healthcare? Oh, prevent the diseases. And that the realization that yes, we can put more money in prevention, but it doesn't save us in the long term either. The realization is not there. It seems like you can't prevent the potholes in roads, but you can prevent the AMI cases or something like this, which is true, but the extra investment in health is still needed. So to turn the general belief, I think Ashish's arguments were very strong, and this is something that has to be more widely shared on government level to the general public, that it's not prevention or treatment. You have to do both. And in case of Estonia, I can refer to the Soviet Union time, and dental care is the most, I would say, extreme example that we can talk about prevention and brushing your teeth, but if the Soviet time healthcare meant that by the time you turned 50, you had lost most of your own teeth, so yes, that the extra benefit for dental prosthesis is still needed in Estonia.
So, Riina, would you say, is there anything, again, because you've been Minister of Health twice, is there anything the second time around that you would say that you would do differently now that you've had this experience being the Minister of Economic Affairs and you know more about, as Minister of Economic Affairs, if you want to pave a road, it's done. Is there a way that you can harness that that capacity and apply it to health, or is it just completely too distinct?
I think that the experience is definitely useful, but still data, strong arguments, and the realizations that no one will give health just money just because we found some. It is my fight. It needs constant pressure. It needs international experience as well. That yes, it is like a rule of thumb that you put more money into health and you get better health outcomes. It is not, and considering the way Estonian health system functions, we can be certain that we can improve coverage, we can offer adequate financial protection, we can offer new medicine and technologies, we can improve our digital solutions, so we actually know what are the things we need to do to deliver and reduce health inequalities.
Great, thank you. Minister Juuso, of course, we're talking about how a health system affects the economy, how it affects using evidence, showing that health is good for the economy. Ashish talked about some work that I've done looking at how improving health among older people is good for the economy. But of course, the primary goal of the health system is not to improve the economy. It's not to grow GDP. Finland is a major supporter of the idea of the economy of well-being. What does the economy of well-being mean in a Finnish context, and how does Finland operationalize this concept in practice?
Thank you for asking. First of all, I would like to briefly describe what the economy of well-being means for us. It aims to understand what is important for people and communities in their well-being now and in the future, and how economic solutions support this. The idea of the economy of well-being is that in addition to economic well-being, the aim is to achieve a good life. It does not increase well-being as an instrument for generating economic growth, but as an objective in itself. Following the European Council conclusions in 2019, the Finnish government launched an extensive network of Finnish experts to plan Finland's national action plan for the economy of well-being. This new action plan aims to ensure that well-being data and information are increasingly used in decision-making alongside economic and environmental data. The data-based knowledge on well-being may include several different indicators, such as, for example, population structure, unemployment rate, number of doctor's appointments per resident, well-being experienced by school children. We have thousands of indicators in Finland. These four is only examples. The key processes in influencing decision-making in the economy of well-being approach include, for the first, collection of data, indicators, statistics. After we have the knowledge-based information, we do a pre-evaluation of our decisions before we go into decision-making process. After decision-making, after a time after it, we do a post-evaluation. What did we got? We monitor and we make conclusions. And that helps us in future to do better decisions, political decisions. The data-based knowledge of indicators for well-being, economy, and environment helps to identify the interdependencies between these areas and to follow up the impact of the measures taken. Do I have some time left?
Yeah, of course.
Finland has implemented a significant reform of health and social services which entered into force at the beginning of this year. Our health and social services were transferred from over 200 municipalities to 21 well-being counties. These larger regions will also be easier to steer from the perspective of the economy of well-being. The government's key objective is to allocate more funding to preventive and low-threshold services, which would reduce the need for expensive specialized healthcare and improve residents' well-being. It is important to note that the economy of well-being is based on the simultaneous implementation of economic, ecological, and social sustainability. We have emphasized this principle both nationally and internationally. What we mean with effective policy measures, we think about gender equality, we think about education, health promotion, disease prevention, social security, health and safety at work, just that kind of things. Thank you.
So naturally, our hope is that the health sector benefits from this economy of well-being perspective, because at least we all believe that health is an important part of well-being. Now, that being said, what should health systems prioritize if the aim is to support well-being? So how can a well-being approach inform budget allocation and priority setting within the health system?
It is essential to disseminate and use effective methods and best practices in all these different countries. Preventive work can promote people's health, well-being, and functional capacity, and curb the growth of healthcare and social welfare costs in the long term. We think so, in the long term, not yet. In the long term, it will do it. The cost of for example, chronic diseases are high, both in human and economic terms. As examples, I would like to highlight the following diseases. We have cardiovascular diseases, the cancer, memory disorders, diabetes, mental health problems, just to mention some. In the aging population, chronic diseases and the risk factors are directly linked in workability and capacity, as well as an increase in the need for services. In all, they cause considerable costs to society. Reducing the disease burden caused by chronic diseases is necessary from the perspective of improving people's well-being and healthy life years, and also for the sustainability of the service system. They can be reduced by influencing, for example, again, risk factors endangering mental health, smoking, alcohol consumption, diet, inactivity, obesity, and loneliness. Loneliness is a new symptom growing in Finland after COVID. Finland will invest in primary healthcare services, in the development of both digital and mobile services. The aim of increasing digital services is, among others, that patients carry out more data production themselves. Diabetics, for example, no longer needs as many control visits to nurses because they can register their blood sugar values in a digital information system that allows professionals to monitor and intervene in the situation only when and if the values deteriorate. In Finland, doctor's appointment can also be virtual. Maybe in other countries too, I think so. But for us, it's really a new, this has significantly accelerated access to doctors. Home hospital services, we have been talking about them before, are increasing, yes, and shortening the time spent in expensive specialized medical care. However, we must remember that the digital services are not suitable for everyone. Older people, in particular, cannot use them, so it must always be possible to meet a doctor or nurse physically. The central government strongly steers and supports the well-being services through we have monthly discussions with the leaders in these countries, and in this way they can learn from each other and compare their practices and find the best ways, the cheapest ways to do the job. Thank you.
Thank you, Minister. Reinhard, we saw in Ashish's slides, Germany, excuse me, has a lot of hospital discharges. Germany is on the higher end of public spending, so public spending on health is in excess of 10% of GDP. So the second highest share of GDP spent on health by government in the European region. And some, maybe you, would say that countries like this spend too much on healthcare, and they don't need to spend any more. They just need to spend more effectively, or maybe they can even cut health spending. In your view, are there risks of restricting health expenditure growth in high-spending countries? And what should high-spending countries prioritize if they decide to restrict growth?
Well, I'm not only from Germany. I'm a child of evidence-based medicine, later evidence-based or evidence-based informed health policy, health technology assessment, health system performance assessment. And I think when you go in from this standpoint, we have to ask here two questions. The one is really how do we measure the health results of what the health system is producing? And I would say that life expectancy is a very bad proxy because there are so many other influencing factors. We know that there is not one uniform measure for the outcome of health systems. The best we have currently, at least for the curative bit, is treatable mortality. And we are glad that from earlier work with some of in the room here have contributed to that we have this joint list of treatable mortality, which should not be there if the health system is doing a good job. We have now retrospective data since 2011, so we can specify that. And the other thing is that I'm totally unconvinced, and for every drug trial, we would never use cross-sectional data. So we always need longitudinal data. And so when we look at this question, we have to ask ourselves, okay, we see all countries spend more on healthcare than they did during the first Tallinn conference. On average, you gave the public figure of about 1% of GDP. Overall, it's about plus 1.5% of GDP. Some countries have increased less, like Estonia, around 1%. Other countries have spent much more, even from a higher level, like Germany, plus 2.5% in the last 15 years. And now we need to bring these two things together and see, how much more health measured in treatable mortality did certain countries get compared to other ones. And there we see that this correlation fades away, that we have no correlation. It's not that countries which have spent more received a better result in terms of less treatable mortality. I think, if in any other area of medicine, we would use such data, and then we say, okay, some countries like Estonia's treatable mortality has reduced 3 times as much as Germany's in the same time, even though the expenditure increase was much lower. So money is definitely not the answer. And so I'm not going as far and say that the opposite would be true. The more you reduce, the better. But clearly, simply saying more money gives you better outcomes is, in my view, looking at these longitudinal data, taking a health system specific result is wrong. And so those countries which then spend less more and receive good outcomes, they would need a proof that they, with an additional euro, would even do better. Maybe this is already optimal what they get. Countries which like Germany have spending much more money, and which have where we see bad outcomes or not comparable outcomes to other countries, then the answer probably is if more money did not lead to good improvements, maybe less money would be the answer, because less money would mean that, at least I mean, it's not in absolute terms. Fortunately, we have inflation, so we could keep absolute numbers down and relative figures would go down. That would incentivize all actors to look for waste, and waste is inappropriate care given to, where there's no health benefit, is inefficiencies, the high number of hospitalizations where you can do it in an ambulatory way. And so yes, I would, in my apparatus of financial instruments, not only have the carrot of more money, I would also have the stick of less money, and looking at the results. And I would say, okay, if you really show me evidence that for an additional euro, you improve more than you did with the current money, then I'm willing to give you more money. But if you don't, I take money away.
But Reinhard, isn't amenable mortality, sorry, now I go off script. Is amenable mortality an appropriate indicator? Because there's lots of other health outcomes, morbidity. Is that the right way to make such a definitive distinction on whether we should spend more or less on healthcare?
Well, no. I said, I mean, if compared to life expectancy, it's definitely an improvement, because it's much more specific. Then we all know that the health system is not only about death or a life. So there are other things when we go in, I mean, quality of life. So yes, there will be more measures, but the countries which are doing not so good in amenable mortality are also not. I mean, then they would need proof that they're doing good in other areas. And I'm simply saying, I mean, we have increased all the expenditure. We could open a bottle of champagne here, because 15 years ago we demanded more money. Now we have more money, and it's our health sector duty also to say what we have done with the money, not only measured in treatable mortality, but also in other useful measures which are available across countries.
And I suppose that also resonates with what Rina was saying about being able to demonstrate, using evidence to support your case and holding the health system accountable.
And maybe one word before, but then I'm old enough to know the World Development Report from 1993. And I remember the big phrase there was, if you have $1 to spend and want to get the most health out of it, invest it in schools, especially for female pupils. And Estonia is doing exactly this. Would I advise the Estonian finance minister to reduce its above average expenditure on education, especially as it is wisely invested? We see the PISA study results. Yeah. I mean, we are all talking in this room about upstream determinants. And then so we then have to be consequent and say, okay, it's good to set priorities there. And if the Estonian health system, with its extraordinarily results in treatable mortality, if they need a bit more, maybe that's also justified, but they need to demonstrate it that they could get results.
David, you're nodding in favor. Do you have something you want to add on this? No, okay. So Reinhard, I'm sorry, one more question for you. So thinking of the 51 countries in the European region that spend less of their GDP on health than Germany, and that don't have the fiscal space to raise spending to anywhere close to 10% of GDP. What's your advice to these countries? Should they increase spending levels, and up to what point? And how can they best make their case?
First of all, Germany doesn't have the fiscal space. We are overspending. I mean, we should have invested more in other areas. When you look across the last 30 years, public expenditure nominally went up 150%, health expenditure 250%, defense 30%. So I mean, we see that we had very, very different priorities than what we heard in the previous session from Estonia here. And so fiscal space. It is first and all is a matter of priorities.
Okay. And what would you tell a lower spending country, one of the Central Asian countries, or countries that spend far less of their GDP?
Well, I mean, if they have, if also for them, it would be good to see whether there are other areas, and if living in peace is endangered by neighbors, okay, they need to spend money on defense. If the children are uneducated, they need to spend money on education. So clearly, health is in competition to other areas. And when you take the Finnish approach of having a good life, there are more areas besides health which have to be taken into account.
Okay. Thank you, Reinhard. David, coming to you. So countries across the region will need to strengthen their case for investing in health, especially if they're listening to Reinhard. Can you tell us about the work the World Bank has been doing to generate evidence on how health systems contribute to productive societies?
Sure. What makes the World Bank different to many of us in the room is that we work across all development sectors, and health is one of those sectors. What also makes us different is our primary relationship is with the ministries of finance and planning in countries. And that gives us a somewhat different perspective. But I think what we consistently see is two things that relate to today's discussion in different ways. The first of which is that most finance and planning ministries tend to think in terms of the social sectors in general, education, health, and social welfare as one cluster. The reason they tend to think of them of one cluster is of concern. They see them as consumptive sectors, as a consumption, not as an investment. And yet, we at the World Bank believe that human capital is and will increasingly be the biggest driver of human growth. So we set ourselves the question, how do we change the perception that health, education, and social protection are consumptive ministries into a recognition that they are investment priorities for development and growth? And to do that, we launched the Human Capital Project, which argues that future economic growth will be driven by human capital formation more than ever before. And specifically, we argued that if children are well-nourished and stimulated, learn skills, and live long and productive lives, that equips countries with the human capital to flourish. And 92 countries have joined the Human Capital Project. And we also have a sister project called the Human Capital Index, which ranks every country in the world on its human capital, with 0 being furthest to the frontier and 1 being at the frontier. And in the most recent Human Capital Index, Singapore ranked highest, but Finland ranked 6th, Sweden 8th, and Estonia a remarkable 12th, coming from a much more adverse history than its larger neighbors. So real achievement, and as Reinhard said, really driven by improvements in health, but also by remarkable improvements in education. And so we have used the Human Capital Project to try and stimulate awareness of financial ministers in the importance of investing in these sectors. And in fact, despite what Reinhard said, not trying to set them up as a competition, but arguing it's a collective investment in human capital. And we would certainly agree that in many contexts, you may want to prioritize education. And Estonia is an example of a country that's been transformed by education and skills. So I might well trade a greater gain in education for continued excellent health outcomes. We're not in competition there. We have a shared outcome. And they contribute to each other's goals as well. And my favorite story about human capital comes from the Singapore Minister of Finance, who attended our first Human Capital Conclave. And he presented what I think is the most powerful graph I've seen in development, and it's counterintuitive. He showed Singapore's investment in primary education since independence. The graph, I wish I had it, went like this. Every year since independence, the amount Sweden has spent on primary education as a percentage of its government budget has declined. And today, it's minuscule. Does that sound like a good thing or a bad thing to people here?
Anyone?
Bad. Well, I'll tell you why it's actually good. Because having invested almost half of its budget in primary education as an early driver of development, Singapore's economy has grown so fast for so long that the aggregate they now spend on primary education, though much larger than before, is a tiny percentage of their flourishing budget. So it's a perfect example of concentrating resources in the right human capital, primary education, at the right time, and as your economy takes off, having money to do more things. Let me pause there.
Thank you. Do you have other examples of countries that have used like the Human Capital Project evidence to support their negotiations, and how has that fed in?
We think that the Human Capital Project has really helped finance ministries to understand that investments in the social sectors are investments, not consumptions. We have great examples from so many different countries, whether Rwanda, whether Costa Rica. This region is replete with examples. So many of our best examples come from Northern Europe and also from East Asia. So I think we see a greater overall recognition of the importance of investment as opposed to consumption in the social sectors, and we have some standout examples from each region. Thank you.
Great, thanks. So we were a little ahead of schedule, but I think that's okay. Ashish, do you want to reflect, since you started us off? Do you want to sort of, I guess, maybe take about 10 minutes or so, or a little longer if you want, or as long as you need?
Yeah, so should I mean, I'm happy to go wherever you want. I mean, I would
sorry,
love...
Did you guys have other comments?
I also wanted
to
argue against Reinhardt.
Yeah, that was great.
It's okay. So there is a new report out that I mentioned briefly, the Financing for Health System Transformation that was released. It actually shows pretty convincingly that spending also lowers amenable mortality. So I agree with you, Reinhardt, that that life expectancy isn't the only measure. And then there is, I would say, reasonable data of change in healthcare spending also being associated with change in life expectancy, which is a better measure. Again, these get more messy over time. The bigger issue in my mind, there are two important points so if someone told me that the real competition is between healthcare spending and primary education, that if you spend less on healthcare, it'll go into primary education, I think there's a reasonable argument to be made that we should cut healthcare spending maybe to put more on primary education. But it is rare in my mind that that's the trade-off. And so theoretically, sure, I am not the person who's going to argue against investing in primary education. It's extraordinarily valuable for society. It is empirically what we see is that countries that invest more in primary education are also the countries investing more in healthcare, and that they rarely are actual trade-offs. That's point number one. Another important point I think just worth mentioning, is there has been a long-standing interest, and of course all of us who are in public health care deeply about and think a lot about the issue of social determinants and how all sorts of social factors influence health outcomes. Completely true. But then you ask the question, how do you actually operationally invest in social determinants of health? Who do you hold accountable? How do you drive change? And while it is true that health is influenced by policies across transportation, environment, the economy, as health leaders, your sort of focus of control is the health system. And investing in health systems, if you invest in quality, if you invest in primary care, if you invest in prevention, I think can have profound impacts on health. May not save money in the short run, may save money in the long run, but from a social good point of view, for a vast majority of countries, I think remains a very, very good investment, especially since I don't see much empirical evidence that you're trading that off against primary education. And so often you're trading it off against other things like roads and bridges, which of course are also valuable. But as a health person, I'm going to advocate for health. So I think that the evidence behind spending on health is a bit stronger than I think my friend Reinhardt. Maybe he and I have a slight disagreement on this. But I think the evidence is actually quite clear across a range of measures that you can really make improvements in people's health.
Rina, did you want to add something first, and then Reinhardt try and defend himself?
Yes, I'm just happy that Reinhardt isn't my finance minister. But I think there are two processes. Yes, we have to strengthen the case for investment into health. And I believe Estonia is a much better position, but coming from a low level of spending on health, you see definite benefit. As long as you have a pretty much functioning health system, strengthening primary care, improving patient pathways, improving access to palliative care, it changes a lot in the society and you get outcomes in a few years. So you can actually deliver, and it's an argument even for the ministers of finance. But at the same time, I don't want to be mean, but let's take the case of alcohol harms. In Estonia, you can be in a situation where it's the role of the Minister of Health, reduce the alcohol harms to the society, but we don't have a political consensus to increase excises, and we don't want to restrict sales or marketing or anything else. Well, how do you do that? But now, since we all aim to achieve climate goals, the Ministry of Economy and Ministry of Climate, for the first time, are in a situation when they have to reduce single-use packaging, reduce waste, reduce CO2 emissions. How do you do it if you can't use tax instruments, if you can't restrict the way companies operate? So the tools they need to use are the same that we as the Minister of Health need to use. So it's easier to find consensus. It's not just the Minister of Health is the only advocate that let's use regulation and different tools to change behavior, because the change in behavior is something that other ministries need to achieve now as well.
I think this is a very important point. And about the co-benefits of investing in health, that go again beyond the amenable mortality as the only outcome indicator of interest. Reinhard, as the person being picked on.
Maybe we should all in the room here realize that there are these two meanings of investment. When many of us talk about investment here, we mean that what usually we term as current expenditure, that current expenditure on health is an investment into health of the population. While many other, including the economics ministries, understand investment differently, that you, for example, invest in hospitals. And so it's not current expenditure. We typically look at the current expenditure, but also there's the investment in
but is this, sorry,
healthcare. Let me make the argument. and when we take other countries, like Germany and Estonia was an extreme comparison. We could compare ourselves with Denmark. And when we go 10 years backwards, we see that Germany and Denmark roughly had the same level of treatable mortality and the same level of expenditure. And then Denmark reformed its hospital sector, something which I often bring as an example. Then people say, yeah, but they had to invest. The investment into building, which was huge. Yes, Denmark invested over a 10-year time period in its renewed hospital sector, 1 year of current expenditure on hospitals. But afterwards, when the reform was over, the current expenditure is on hospital care is lower, and overall their current expenditure on health it has almost not increased. When you want to look for a country which has not increased current health expenditure, is Denmark. And when you then wonder how did they do it, because they literally use this classical investment. And I think we have to disentangle that and say sometimes, and for Germany, coming back to your first question, that would be wise to say, okay, with a long-term goal of reducing current expenditure, and this is what I mean, less money on health, we need to do certain real investments to have a more efficient health sector, fewer hospitalizations, more ambulatory care, less inappropriate care, and so on. So we need to take this into account, that not simply giving money into the current system, but to rebuild the system takes money. Estonia used the structural funds of the EU for this, and I understand that these are running out now, so you have also challenges to maintain the capital.
But I have to say that we serve as a pilot site for Germany, so the German taxpayer has renovated our hospital network.
But we are not looking at you then enough.
And Definitely, we have saved money in the longer term. So based on the Estonia example, now you can invest into the German hospital network. you got an argument.
Yes.
Okay, we're getting shorter on time. Ashish, do you want to wrap up your thoughts here and listen to the panel? And
Yeah, I feel like I've sort of made most of the points I want to make. And as I hear the conversation, let me just maybe very quickly add a couple more things, and then we'll see if anybody else wants to.
Sure.
I think one of the challenges we face in the healthcare space, and I think the Estonian health minister really, she got us started on this, is the investments in healthcare or in health feel much less tangible than building a road, building a bridge, right? And therefore, are always a harder case to make. By the way, just as a side point, the way the United States has dealt with this problem is basically having no budget for health. It's a terrible way to deal with the problem because it means our spending is completely out of control, but it does make it easy to not have to make the case for spending. Most countries are far more disciplined than that, and you actually have to make a case. I think at the end of the day, and maybe Reinhard and I actually probably agree more than disagree, for many, many countries, there is an important case to be made, as hard as it is, as much as it requires behavior change, to make the case and to fight for health. I think what we heard from our Finnish health minister about broadening that landscape beyond thinking about health to really thinking about well-being and all of the metrics that go into it, it actually gets you out of the problem that we've been discussing of, are you investing in primary education, which we all think is extraordinarily important, or are you investing in more primary healthcare, which we also think is really important. If you have a broader measure of well-being, it gives you a much easier guide for knowing for your country where do you want to do it. The challenge is you need lots of metrics, many, many metrics. You can't do it with amenable mortality or life expectancy. You said thousands of metrics go into your into your model. That is very hard for many countries to do. But investing towards having more measures of well-being, I think, begins to make it easier to have a more evidence-based discussion on this. And let me just kind of make the last point that we've talked about, which is, I do want to come back to a point that sort of has been made a bit, which is, given the changes that are happening in the healthcare system, the emergence of new technologies, there is going to be increasing pressure to spend more on health. Like, I think that is just going to be very, very hard. Populations are going to want, there are new gene therapies that are coming that are extraordinarily expensive, but life-changing. One-time treatment, at least in the United States, we have our first gene therapies getting approved, $2-3 million for a one-time treatment, but then you're cured for life. The pressure to give people access to these things is going to be enormous. It's going to be very hard to say to your population, yes, you can get it in America, yes, you can get it in Finland or Germany, but you can't get it here. That's going to be very, very hard over the long run. And part of preparing for that day, which I think is coming sooner rather than later, is making the kinds of reforms that we've been talking about. So again, I don't think Reinhard and I disagree significantly. Like, the way we're doing healthcare right now is wasteful in lots of places. I mean, certainly true in the United States. I think Germany could be more efficient. I think many countries can be more efficient. But I think the notion that we're going to get through the next 5 or 10 years without spending more on health, I think it's going to be very, very hard, and you're going to get a lot of pushback from your population. So I think being ready for that and finding ways of making sure that spending is more efficient is really, really, really critical.
Great. Thanks, Ashish. Thank you, panel. Maybe a hand for the panel. And I encourage you to read our policy brief on spending more, spending better. Maybe some of you have it. It's probably somewhere in this room. And otherwise, I think it's time for lunch. So many thanks. and have a nice lunch.